So I know many of you are not going to be getting pregnant, but many of you have been, and I'm sure many of you do worry if you are sometime going to become pregnant. I'm going to be talking mainly to the women, but some of you are married to them. There are specific problems when you have ITP. First of all, menstrual bleeding. And it can become so severe that women can become anemic. I've had to have patients admitted to the hospital because they've become so severely anemic or because they've bled so heavily. The other thing is fertility, and this is going to be true for both men and women, that many of these drugs can affect your fertility. And so that's something that whether you're a man or a woman, it has to be discussed with your physician if you're planning on starting a family, whether or not you're willing to take a certain drug or to be on that drug while you're trying. And then, of course, pregnancy and then breastfeeding, which we will get to as well. So, of course, if you don't have platelets, they're very, very important in stopping the bleeding. The menstrual bleeding is normal until you can't stop it. It's very, very important to explain to your physician exactly how much bleeding you're doing, because a lot of women will say, oh no, it's normal, whereas you may think that's normal, but really once you start talking about how much bleeding it really is, really getting down to how many pads, how many tampons, how many days, your physician may say, that's actually not very normal. And we're fortunate in that the first thing we can do is we can use something called tranexamic acid, which is readily available. There are relatively very few, almost no side effects to this drug. We used to worry quite a bit that, well, if it stops bleeding, maybe it will increase having an abnormal blood clot, but in 50,000 patients with hematologic disease who've gotten this over the last 20 years, there was recently a study that put all of these data together. There was absolutely no increase in thrombosis or abnormal clotting at all. And I have seen this drug work not only, and it's important for everybody to know about this drug, not only in women who are having heavy periods, but people who come into my clinic or might call me up at night and say, I'm waking up and I've got blood all over my pillow, I've got blood blisters in my mouth, and I have every one of my ITPs that are unstable. I tell them you must have this drug with you all the time. If you're a man, it should be in your wallet. If you're a woman, it should be in your wallet or your purse. Or if you're a man, you can have it in your purse too. Well, in Europe, they all carry purses, yeah. And literally, I have had patients call me in the morning, say, oh my goodness, I woke up with blood all over my pillow. Oh my goodness, take that medication that I gave you. I want to see you first thing as soon as my clinic starts this afternoon. They'll come in completely clean. And I'll say, I thought you had blood blisters. They all went away. And one patient who did this to me twice, the second time he called me, I said, oh, take the medication. And he said, oh, I already did. I just wanted you to know. Because it works that well. And so seriously, if you've got bad ITP or even mild ITP and you're somewhat worried, certainly if you're traveling, it's something that you should have. It's incredibly safe. So you should tell your doctor, I want a prescription of this, and fill it and keep it with you.
Sorry, saying that, how does that affect? So I know personally I had a blood clot.
Yeah, so I would not give, so the way this is working is there's a normal process in the body that breaks down your clot. Obviously, we all have to make a clot. Everybody has cut themselves shaving or cut themselves with a knife, and you get a little blood clot there, and you can look at it. And what I usually say to my patients is, okay, you've cut yourself shaving, can you show me that? Show me that little blood clot that you made. Well, it's not there anymore. Well, we don't have magic in our body. Something had to happen to that blood clot, and there is an enzyme that breaks that down. And what tranexamic acid does is it slows down that breakdown of the clot. So if you're making a clot much more slowly, you may be breaking it down before you can actually stabilize it. But if you have a blood clot, even if you've got a low platelet count, this is not a drug that we like to give to people who have blood clots. And we're going to have a big study that's going to be published soon about its use in leukemia, but I'm sure it's going to be very similar in terms of what we see. But for women also, we might use oral contraceptives that can regulate the periods and that can actually decrease the bleeding, or we can start IUDs or progesterone implants. The other thing is that there can be a lot of irregularity due to these medications. Prednisone will affect it. There are other chemotherapy agents that we sometimes give that can affect that and cause irregularity or infertility. So it's important to recognize that and talk to your physician about that. So I mentioned that many medications can affect fertility. People don't think about this, but being on high-dose corticosteroids can affect your fertility. And we have used cyclophosphamide in some patients who have very bad ITP. And I always talk to young women, if we're going to have to use this, about the fact that we may decrease their fertility by using this, although really most patients will remain fertile as long as we don't continue the therapy for months on end. What drugs do we try to avoid pregnancy in? Rituximab, and I'll talk about this a little bit more, but we will come to rituximab. I usually tell my patients if they've gotten rituximab, I'd like you to use some kind of contraception for the next few months. Mycophenolate, I don't think people should get pregnant on at all. The TPO receptor agonist, but I'm going to come back to talking about that, and certainly danazol because it's virilizing, and the chance that you're going to get pregnant is very little, and the chance that if you do get pregnant that you'll carry it to term is pretty poor. So let's talk a little bit about what happens to platelet counts in somebody who is pregnant. And these are control women. These are normal platelet counts, so generally 150 to 400,000. Some people will be on either side of normal and will still be normal. But when you get pregnant, it all shifts. So you can see there's been about a 10 to 12% shift in what is a normal platelet count. Some of that is dilutional because the blood volume really increases. Some of it may be due to increased platelet turnover. But it is not unusual to see the platelet count. In fact, we expect the platelet count is going to come down somewhat in a woman when she gets pregnant. And as the pregnancy goes on, it's going to be more and more dropping that count. And this shows you just exactly how much we really drop that count. We drop it. Here's pregnant women versus control women. You can see that their average platelet count was somewhat lower. And then their lowest platelet counts, when you get down to the very end, are really actually below what we would generally consider as normal, but these are still normal women. So when you have a patient who presents to you with a low platelet count in pregnancy, especially if it's just the low platelet count, there's many reasons why women may have trouble with a low platelet count. A lot of it is preeclampsia, very severe complications of pregnancy, and then of course viruses and nutritional deficiencies. But you can get just a low platelet count, as I mentioned, just from being pregnant. We call it gestational or incidental thrombocytopenia. But of course, ITP, there are some drugs that will do it that we give to pregnant women. Some people have an inherited low platelet count, and then there are some people who have a bleeding disorder called von Willebrand disease that may cause a low platelet count and may not have been noticed before this. Occasionally we get a woman who comes in, this is the first time that she's ever really had a platelet count done, and her platelet count is low, and now we've got to figure out, well, which of these might it be? So fortunately, very few of these are actually going to be an immune disorder such as ITP. The vast majority of these are called incidental or gestational thrombocytopenia. And luckily, these women do beautifully. They never have a problem in pregnancy that's related to this. But we can see quite a few problems in pregnancy related to ITP. What's interesting is that you don't have to have ITP to get ITP of pregnancy. So there are women who, for the first time, get ITP, and they may have it only during their pregnancy. As soon as the pregnancy is over, they no longer have ITP. There are women who get it for the first time in pregnancy, and unfortunately it never goes away, or it takes a year or two before it goes away. And then women who have ITP typically get worse during pregnancy and have to be watched a lot more closely than we normally would. what helps us somewhat in the diagnosis is that this is the most common cause of having a low platelet count in the first trimester. So when I get referred someone who is very early in their pregnancy who has a low platelet count, I'm now thinking this is not gestational, which usually occurs a little bit later as the blood volume increases. I usually am thinking, well, you really have no business having dropped your platelet count yet, and now we may be looking at ITP. It's very similar to ITP in anybody who's non-pregnant. Luckily, most of these women get away without any kind of treatment, but about a third of them are going to require treatment. And of course, certainly for anybody who's had children, you know that the thing you're worried most about is not me, I'm worried about my baby. Is my baby going to be okay? That's what we all worry about. And unfortunately, about 20% of these babies will have a low platelet count. 4% of them will be severe, meaning under 20,000. But the babies almost always do well, and that's what I really want the take-home message to be. These babies do just fine, even with the low platelet counts. So how do we make this diagnosis? These are going to be the questions that I think we need to answer. First of all, one of the ways I do it is by saying, how severe is your platelet count? How is the thrombocytopenia? So if it's just very mild, it's much more likely that what I'm looking at is just gestational or incidental. As the platelet count drops, we start to see that ITP starts being a bigger and bigger portion. And so that when we get down to counts in the low 70, below 70, we pretty much say, although you can sometimes see it, that that is unlikely to be just gestational or due to pregnancy alone. It's much more likely there's something else going on, either ITP or one of the disorders of pregnancy, such as preeclampsia. So although this says 25%, I think when you start really getting down below 70,000, we're really having to start saying there's something else going on here. So we do basically the same testing. I mean, if this is the first time a woman is coming in and showing a low platelet count, the testing and how we're going to exclude other causes is going to be similar. I'm going to ask, have you had bleeding before in the past? Have you had heavy periods in the past? Have you ever had a blood count done? Let's dig into your past and look at whether or not you had something when you were going to university. Somebody may have done a CBC, or when you were going to camp. Or if you were going to travel overseas and your physician decided to do that. So those are the two things. And then, of course, a physical examination to see if there's anything else that may be suggesting why there's a low platelet count. Some of the congenital disorders, you can have other manifestations that are things you can see, and that may give me some kind of clue. I may be asking about anybody else in your family have a low platelet count, if that's the first time I'm going to see them. So again, we talked about timing and severity. We'll be doing a CBC, a total CBC, to see if there's any other abnormalities. Many women who are pregnant are also anemic. But one of the things we need to do is get down to that microscope and look in the microscope, look at the platelets. Do the platelets look normal? Does everything else look normal? Are the red blood cells abnormal? And that's going to help me decide whether or not there's another hematologic problem. Women who have hypertension of pregnancy, particularly who are preeclamptic, may actually have very, very severe thrombocytopenia, and that can be an emergency. Infections, viral infections in particular, and other laboratory abnormalities like clotting abnormalities will help me know whether or not this is just ITP or something else is going on. So again, what I'll be doing is asking about whether or not they've ever had a low platelet count before, a bleeding history. I'll be looking at their blood pressure. I'll be reviewing the blood smear. And one of the things that's very important to recognize is that those counters in the laboratory can't necessarily know that this isn't real. So sometimes what happens when you collect the blood is those platelets all clump up together. Some of the substances that we put in those test tubes, some people have a tendency to clump their platelets. It doesn't cause a problem in the body, but it causes a problem in the laboratory because the way we measure this, the way these machines measure this, is by the size of the particle. And so the platelet falls into a very specific size range. if they're too large, they don't get counted in that size range. And so when you go down to the microscope, you might look in the microscope and go, well, there's plenty of platelets here, but they're just all clumped together. And so we can retest in a different substance and actually say, you know what, the patient isn't thrombocytopenic at all. We may see large platelets, which might suggest to me that there's a congenital disorder, and there may be fragments of the red cells, which would suggest something like preeclampsia. And then lastly, we talked about laboratory abnormalities, certainly looking at clotting testing, looking for other bleeding disorders. But one of the interesting things is that other autoimmune diseases are frequently associated with ITP. And one of those is abnormal thyroid testing. Most of our thyroid diseases are autoimmune, actually. And so it's very common to have people who not only have ITP, but either have a very overactive or an underactive thyroid. And what's interesting is if you treat the thyroid, the platelet count gets better. I can't tell you why that might be. Do you have any ideas why that is? I have no idea, but it happens. It's interesting. Liver function tests, because there are some liver abnormalities in pregnancy that are associated with low platelet counts. And then, as we do in ITP, testing for viruses and other autoimmune disorders. So what happens while women are getting pregnant? Well, as I mentioned, or while they're carrying their baby, and as I mentioned, as you go through pregnancy and you start expanding your blood volume, there's a lot of changes going on. Everybody starts to drop their platelet count a little bit. But, you know, for most women who have an uncomplicated pregnancy, they're not going to drop into any kind of range that's going to be at all concerning to the obstetrician. But if you're already starting out on the lower side, or if you have a pregnancy-related complication, you're going to drop much more quickly. And the problem becomes that as you continue to drop through your pregnancy, you may start reaching numbers that the obstetrician is going to be very concerned about delivery and how you may be doing with carrying the baby. So this is going to be a different answer for me than for the obstetrician. Obstetricians don't like low platelet counts. They're scared of them. And I think if you ask most hematologists, oh, the platelet count's 10,000. Well, that's okay. Are they bleeding? But if I said to an obstetrician, oh, don't worry about that 10,000 platelet count, they'll look at me like I'm crazy and they'll send the patient to another hematologist. So we've got to kind of find, right? So you've got to kind of find your balance with the obstetrician. So that's one of the questions I get is, when should I start to treat that patient? And what can be safely used during pregnancy? Because obviously the fetus is much more sensitive to drugs. And that's, again, what mom is concerned about is this going to hurt my baby? And then, of course, most women want an epidural. At least in the United States, they do. I don't want anything natural. I don't want to be feeling this. I don't want to be screaming. So they'll be asking for, what can I get an epidural at this platelet count? And of course, we're going to be talking to the anesthesiologist about that.
He's almost more afraid of the low platelet count than the obstetrician.
That's right, because they're sticking the needle in. And I have had many operators of all kinds of procedures, when I tell them it's safe, say to me, well, then you do it. And it's, no, I can't do that. I know I can't safely do it. Okay, and then the last question is, am I going to need a C-section? Because I'm worried about my baby. If you're telling me that my baby could be somehow affected, is it going to be safe for them to be pounding their little head against the pelvis? Is my baby going to be okay if we do that? Maybe we should just take that baby by a C-section, and that way they're not going to have all that trauma. What I want to do, and I hopefully you'll think this is fun, I'm going to show you an interview that I had with one of my patients that we videoed. She was very gracious. She knows I show this all over the world. She was diagnosed with ITP at age 10 when she had some petechiae. She was given steroids when her platelet count would fall with upper respiratory infections. And she was pregnant for the first time in 2007. Her platelet counts were a little bit low during the first and second trimester. When she got down around here, the obstetricians became uncomfortable and started treating her with prednisone. And then she says, I really want an epidural for my delivery. I'm a little bit concerned about this. And of course, prednisone is not the best thing for a pregnancy. As you can imagine, there's weight gain, there's hypertension. people don't do well for long courses on prednisone.
We actually showed the doctor the rash, and then that's when I was diagnosed. So somewhere early teenage years, it was actually diagnosed. And I was sick, they would go down. And so I would be given different amounts of steroids, but all in all, it was just prednisone, and then they would go up and I would be okay. It wasn't until my first pregnancy, and not even at that, it was the tail end of the pregnancy, because the first time I was pregnant, I was trending in probably between 50 and 100,000. And so it wasn't until delivery that really became a problem.
How low was your platelet count right before
I delivered on my first pregnancy, it was right around 40,000. And that was despite attempts with prednisone.
Did they try IVIG at that time on you?
No, just prednisone.
And so were you not able to?
Epidural?
An epidural?
No. And they lied to me, by the way. Every doctor told me if my platelet count was 50,000, I'd be able to get one. So, but no, it was 100,000. So it was a natural delivery.
Poor lady. So what do we do for ITP in pregnancy? In the first 2 trimesters, pretty much we only treat if the patient is symptomatic or if the platelet count is dropping really below 30,000. This is an argument that I'll usually have with the obstetrician, but I can usually calm them down and let somebody run around 25,000. If there's an amniocentesis planned or some other procedure, we might treat them for that. And then, as I showed you, it continues to drop, certainly as we get to the 3rd trimester. And at that point, it sometimes starts to drop precipitously. So at this point, I'm going to be testing a lot more frequently because number 1, I don't know when that delivery is suddenly going to show up. And number 2, I know that they can quickly drop and I want to protect her. But this is important. The therapy has to be directed for protection of the mom. And I'll show you some data that suggests that no matter what I do to mom and no matter how high I get her platelet count, that is not going to touch the fetus. And so the baby is going to do their own thing no matter how high that platelet count is. So the therapy really has to be based on her risk. And I can't be thinking about whether or not I should treat mom to help the baby. So the first-line therapy is going to be the same as it is in regular ITP without pregnancy. We're either going to use steroids to get it up more quickly, IVIG, and sometimes I combine the two, and that will, if one or the other is not working, the two of them together might work much better. We rarely, I haven't performed a splenectomy in a long time. He's done it for pilots. I've done it for people who they say, I'm going skiing and I'm going to do my dirt bike riding, whether you like it or not. And that was the last splenectomy I had to do. Well, not personally do. But we rarely perform this in pregnancy. If you're going to have to do it, we do it mostly in the 2nd trimester when we're past the point where the baby might be hurt by the anesthesia. And also the uterus has not gotten so big that they can't get around it. But we really try to avoid that. The drugs that are safe is athioprin. We can combine these different drugs. And cyclosporin, which is an immunosuppressive, is actually safe. We use it very often. We continue women through their pregnancy on this if they've had some kind of organ transplant, such as a liver or a heart transplant. And we know it's safe in those circumstances, so we can sometimes use that during pregnancy. So let's talk about what we don't want to use. The other immunosuppressive drugs, things like mycophenolate, vincristine certainly, danazol because of the virilizing. And then rituximab actually has been used during pregnancy. The issue is that just as it will do to you, which is to drop out all of your lymphocytes, or at least a certain type of lymphocyte, it's going to get across the placenta and it's going to do the same thing to the baby. And so the baby will be born somewhat immunosuppressed. If you're breastfeeding, that tends not to be a problem because that's where the baby's getting most of their antibodies anyway. And if 6 months later, the baby will have developed its own immune system, the lymphocytes are coming back, it won't be an issue. And relatively contraindicated are the TPO receptor agonists, but I can tell you that we have very safely used them. There are only 6 reported cases in the literature, but I can tell you there's a lot more use of that going on. It just hasn't been published. Whereas eltrombopag, I'm a little bit more worried about. They both get across the placenta, but eltrombopag has had some problems with fetuses that we know about in certain animals, in particular baby mice, I think also. And so it's just not a drug that I ever recommend using in pregnancy, but we've certainly used vermiplistim. And then David just talked to you about the recombinant human TPO that's been used in China and appears to be very safe, but I don't know that we're going to have it at all. But they did have some very good responses. The important thing is that in all of these trials, the babies have been perfectly fine, perfectly normal. They haven't had ridiculously high platelet counts. I can tell you that the women that I've done this with have either been in so much trouble towards their end of their pregnancy that I have no choice, or a couple of women who were told, don't get pregnant on this drug, and they said, okay, doc. And they went right home and got pregnant. And they said, what is she going to do about it, right? She's going to take care of me. I know she will. So, and we've had to keep them on. So what about delivery? Well, I talked about the fact that it's really determined by the obstetric indication. So we're not going to change the delivery by the fact that the baby may be thrombocytopenic. It's really only if the baby is in some kind of distress, they're not proceeding with their labor normally, and for the same reasons that we would deliver by C-section. Unfortunately, in the United States, I hope this doesn't go on here, we've got women who demand C-sections for all kinds of reasons. I want my baby born on a certain day. Oh yeah, we've seen all kinds of things. So we don't do that with our ITP patients generally, but that's not an obstetric indication in my mind. And then epidural anesthesia. We don't know the risk of spinal hematoma, but I can tell you that above 70,000, we have not really seen it. Not a paralyzing spinal hematoma. There's definitely a little bit more blood lost when you start getting under 100,000, but it seems to be apparently very safe when we get as low as 70,000, and most of the guidelines will say a platelet count of 70,000 is fine for an epidural. You can also have just a spinal. Now, an epidural needle is a very big needle. For women who may sometime go through this, don't look at the needle, okay? Because it's big. But there is a little tiny needle that they can use called a spinal anesthetic. And it's a little thin needle, and that needle can more safely be used. And most anesthesiologists will let you go down to 50,000 to use that. So what about doing a C-section? Is it safer for the baby? I just told you that the baby may be thrombocytopenic. Is it better to do a C-section and just not have that baby come through the birth canal? There have been a lot of case reports looking at this and comparing mothers with ITP and the babies who were born either by C-section or delivered vaginally. Absolutely no difference in intracranial hemorrhage. In fact, babies are somewhat hypercoagulable, or if you would, I don't want to say prothrombotic because they're not actually going to make a blood clot, but it's a trauma coming through that birth canal, there's no question, and babies already have higher levels of other things that make you stop clotting, so that's probably why they're so relatively protected. But absolutely no difference in any of these. This is only 17, but this is 474 cases, and they saw no difference in intracranial bleeding in those babies depending on how they were delivered. So here's my patient again.
I just happened to see some petechiae on his forehead and said, shouldn't we test his platelets? I mean, and they said, oh, it could have been just from coming through the birth canal. And then thank goodness we did look, and it was 50,000. About day of life 4, it was 16. And then by probably day 7 or 8, it might have been at that 7 mark.
And what did they do then?
IVIG, several rounds of IVIG, and then platelet counts as well. Or, sorry, platelet transfusions.
So how often did he have?
He ended up getting that about 4 times. 4 to 5 times was probably about 6 weeks after his birth.
He recovered.
Mm-hmm. And then he recovered. Yeah.
And he recovered. And how high did he go?
Oh my goodness, they were in the 600,000 the last time we looked.
So she's telling you a few interesting things about this. That he did have petechiae on his forehead when he was born. And luckily, mom said, she was smarter than the obstetrician, who said, oh, no, don't worry, it's just coming through the birth canal. Babies don't do that coming through the birth canal. That's not normal. And she was smart enough to say, I want to test that baby. And sure enough, he was thrombocytopenic. And very typically, that's not the lowest they're going to go. They're going to drop over the next 4 to 5 days and may hit rock bottom. And indeed, this baby really did get low. At which point they treated him with IVIG. These babies do extremely well, but we're pretty sure that what's happening here is that her antibody went across the placenta, just like a normal antibody would. That's how babies are protected when they're born, is that they have a nice complement of the mother's antibodies. But unfortunately, that included some abnormal antibodies. And the babies generally respond beautifully. Usually by 2 months, this whole adventure should be over for the baby. And indeed, this baby did pretty well. And one of the things that mom is going to ask is, well, okay, this isn't my last baby. I want more babies. What's going to happen next time? It's been looked at how many babies actually do get into trouble when their moms have ITP, and we can see a reasonable number. This is a very small study, but these were more patients than that. And you can see about 10% of the babies will be below 50,000, and about 4% will have very low counts. But what's very nice to see is that none of these babies either had an intracranial hemorrhage or died of any kind of bleeding or other issues. So the babies do great. They have a low platelet count, they may have petechiae, but they do beautifully. What was done for this baby is what we typically do. There's a very low mortality. One of the most important things, any of you who is going to have a baby, you tell your obstetrician, I want that umbilical cord blood sent for a platelet count. Because rather than sticking your baby, we can get a platelet count immediately on that cord and we'll know where we're starting. And again, what we have to be worried about is that platelet count is going to fall further over the next few days if it's low, and then the baby is going to need to be retested as we move forward to make sure that that platelet count doesn't get too low. Most babies will get a shot, an intramuscular injection of vitamin K, because babies are born with low vitamin K levels. So frequently they just, as soon, I think at day 1, day zero, they get an injection of vitamin K. So the obstetrician has to be told, no, do not do that until we know that platelet count is safe. And then as we talked about, that platelet count is going to fall and may last weeks to months after that. So I think she has one more thing to say. So then you got pregnant again in 2000 and...
Well, at 10.
Okay.
She was born in 2011.
What's that pregnancy?
That pregnancy was a little bit rockier with the platelets because, I have my issues when I'm sick. I had now a son in preschool, bringing home lots of preschool germs. And in December of 2010, I got really sick. And so that's when we really started having to deal with my platelet issues, and it got down to 6,000.
And so how were you treated?
At that point, still with just prednisone. And I was on prednisone, varying doses. At time of delivery, I continued to drop. But it was probably about 38 weeks pregnant. I had a routine platelet count check, and it was low. And so I was admitted to the hospital for IVIG, which my platelets still weren't close to 100. So again, no epidural. I'm a little bitter about that.
But what was her platelet count at birth?
Her platelet count was about 55,000. And thought maybe she was going to be okay. But we tested again about a day of life 4, and she was down to in the teens. And so she got lots of platelets, treated a little differently, given more platelet transfusions to help those antibodies get gobbled up versus she only had 2 total doses of IVIG.
And
Yeah.
how long did it take her to recover?
3 months. Yes.
And is breastfed now?
Correct, yeah.
And what was her last platelet count?
Her last platelet count was, it was also, it seems like when they recover, then they have an abundance of platelets. And I think it was like 500,000. So it was a hefty amount.
So what's interesting is she's telling you the exact same story that she just told me about her son. The stories are almost identical. It's as if history has repeated itself. And if we look at how the mother's platelet count and the baby's platelet count relate, they don't. You can see here's mom's platelet count at the time of delivery and baby, and it's just all over the map. So we can't predict what the baby is going to do based on what we've done or managed to get with the moms. And I think that's really important, that we shouldn't be thinking, well, just keep treating me because I want to make sure my baby is going to have a nice normal platelet count. And in fact, if you look at women who've been treated with IVIG or corticosteroids and the baby's platelet count, again, there's absolutely no relation. So is there any way to predict what's going to happen? And there is, in fact, because here's her first baby and the first baby of several women. And here's the platelet count of the second baby. And this line going through here describes kind of a one-to-one correlation. So it may not be exact, but you can see that if mom's first baby had a low platelet count, the second baby tends to. It is almost exactly the same. And where they fall to at day 4 or 5 seems to be exactly the same. So that's really the only way to predict what's going to happen to baby is by seeing what happened to the previous sibling. One of the things that's important is not to try and find out that platelet count before delivery. So first of all, I already mentioned that it doesn't matter what the baby's platelet count is. You saw her 2 babies were thrombocytopenic and were fine. We don't need to go in there and try and there are procedures where you can actually take blood from the fetus. And that's riskier than the mom delivering without knowing that. So we absolutely should not be doing that. It probably causes more damage than just allowing that baby to be born vaginally. So in summary, ITP luckily is very uncommon in pregnancy. We manage them pretty much the same, other than the fact that there are some drugs that we just can't use. But many of these babies may be thrombocytopenic when they're born. They may be severely thrombocytopenic. It's important, even if they're not very thrombocytopenic, to continue to follow them, because as she said, everything was, 50,000, not so bad. Platelet count dropped to really significant levels. The nadir, the lowest count, may occur several days later, and it can last weeks to months. And one thing that I didn't mention about this, and this is really important, and it's why I asked her if she had breastfed her baby. There are antibodies in breast milk. That's one of the reasons why breastfeeding is so good for babies, besides just developing the relationship between mom and her baby. We're actually delivering antibodies to protect the baby. And again, unfortunately, those antibodies can be passed across the breast milk. So if a baby is not getting better, despite, time has passed, it's now 2.5 months, one of the things we can ask mom to do is to hold the breastfeeding, just pause it. We don't want her to not pump because we don't want her to lose her chance to do it, but we'll stop the breastfeeding for a while to see if the platelet count comes up. If it does, of course, we don't know now, is the baby going to get better? We'll restart the breast milk and see whether or not the baby then drops their platelet count again. Luckily, intracranial hemorrhage is rare. It probably occurs definitely less than 0.1%. And certainly, it's not a contraindication to future pregnancy. In 35 years that I've been treating these women, I have told exactly 3 women, you really cannot do this again, because we're so worried that we're going to wind up with a baby without a mom. So, that no one should tell a woman that she should not get pregnant because she has ITP. But certainly, I think you need to be taken care of by a high-risk obstetrician, and a hematologist needs to be partnering with them. So As I said, a history of ITP during pregnancy is definitely not a contraindication to future pregnancy, but history does repeat itself. So something to remember. And there she is we have a Halloween. I don't know if you guys celebrate Halloween, but there she is with her babies there. So thank you very much.